University who will join us as speaker in today's first plenary sessions of the conference. And dear respected fellow lecturers and committee whom I am so proud of. And last but not least, dear our conference participants who engage in the 7th International Conference on Translational Medicines and Health Sciences. Thank you to each and every one of you for being here today at this wonderful place, as well as via Zoom meeting online. My name is Ictmhs, and it is a pleasure for me, such an honor for me to be a moderator on the second day of the conference. And let me begin by giving you a bit introductions on the upcoming event. Today is the second day of the conference, and we know on the first plenary sections. And today we are very lucky to have two expertise who have a great experience working in the field of genomic and personalized medicines. And our first speaker is Professor Dr. Gunadi. He will share to us the genomic and personalized medicine perspective in Indonesian research. And the second speaker is Dr. Nani Maharani, who will give us some information related to the use of personalized medicines in inherited cardiovascular disease. Okay, now let's proceed for the first agenda. For the first speaker, we have Professor Dr. Gunadi with us today. Can we check the Zoom? Professor Gunadi is there already? Okay. Before we begin, I would like to read the curriculum vitae from the Professor Gunadi that he already sent to us. Professor Gunadi is a professor in the Faculty of Medicines and a pediatric surgeon in the Department of Surgery, Dr. Sarjito Hospitals. He was graduated from bachelor programs in Jamada University, doctoral program in Kobe University. He had many experience in fellowship program, and most of them is abroad, for instance, in Singapore, Japan, United Kingdom, and United States. And currently, he is a co-director in the Biomedicals and Genome Science Initiative for Precision Medicines. Furthermore, he was engaged in more than 23 research in the field of genomic and has already published more than 100 papers related to genomics research in high-impacted journals. Thereby, he has many experience to share with us today related with the topics that we will be discussing in the next 45 minutes. And Professor Gunadi has joined with us today, but unfortunately, due to his strict agenda, he couldn't present the lecture. Yeah, I'm sorry for the problem. Yeah, so because of his strict agenda, the lectures will not be presented directly. However, he provided us with recorded material, and he will be here today at the discussion sections. And please, ladies and gentlemen, if you have any questions, please write in the chat box or activate the raise hand features in the Zoom meeting online, and we will back to you at the discussion sections. And finally, ladies and gentlemen, without further ado, please join me in welcoming Professor Gunadi. Please give applause to Professor. And then, Professor, the time is yours.
Morning, ladies and gentlemen. First of all, I would like to say thank you very much for the opportunity to present the research title Genomic and Personalized Medicine Perspective in Indonesian Research, the current condition in Indonesia, or the 7 Ictmhs, Semarang, Indonesia. My name is Gunadi from Universitas Gadjah Mada. Before we start the talk, let me introduce our Indonesian Society of Human Genetics board member from 2021 until 2024. And one of the vice president is coming from Universitas Diponegoro, Dr. Nani Maharani. And this is member of INA is SG from Sumatra, Kalimantan, Java, and Sulawesi. Hopefully, soon we can have a member from Papua. And this is the vision of mission of INA is SG for quality of life and well-being community through education, research, and community services, community awareness on human genetics, board of certification, etc. And what we have done so far, we have INA SSG Live Instagram, lecture series, collaboration, research collaboration, and we also have the INA SSG Malaysian Society Human Genetics bi-monthly webinar. And this is the outline of our talk today. The first is genomic precision medicine, the second global precision medicine and precision medicine in Indonesia. Genome. Before we start the genomic medicine, let's talk about human genome first. I think I will explain briefly. Nuclear genome consists of 3 billion base pair and consists of 30,000 genes. And interestingly, only 4.5% highly conserved, including 1.5% coding DNA. And the other 3% of conserved untranslated and regulatory sequencing. How about the remaining? The remaining of 95.5 is non-coding DNA human genome, such as tandem repeats, etc. Besides the nuclear genome, we also have mitochondrial genome, consists of only 16,000 base pair and 37 genes. And human cells vary in number of mitochondrial DNA molecules. And interestingly, sperm do not contribute mitochondrial DNA to the zygote, strictly to maternal. During mitosis, mitochondria are passed on to daughter cells by random assortment. This is when we compare between nuclear and mitochondrial genome. Like I explained previously that nuclear genome is very big, 3 billion base pair, and mitochondrial is approximately only 16,000 base pair. And this is the genetic diseases. By definition, actually, genetic diseases is if there is a variant in stretch of DNA. However, some classification include the chromosomal disorder as well, and it relates to the diagnosis, molecular diagnosis. How do we detect? Depend on the kind of genetic diseases. For instance, single gene disorder we may detect by clinical whole exome sequencing or clinical whole genome sequencing. This is the detection approach development from light microscope and then karyotyping, microarray. Now we do have the NGS, including exome sequencing and whole genome sequencing. This is the resolution, the difference between all of the detection approach from the number of loci probe, variant detected, variant proportion, and also the diagnostic yield, incidental finding as well. From the light microscope, the diagnostic yield and incidental finding is very low. And when we move to the right side, whole genome sequencing, beside the diagnostic yield is very high, but incidental finding also very high. This is uh, the how do we detect genetic disorder depend on the classification of genetic diseases, like I previously explained. For instance, chromosomal abnormality we may detect by CNV-seq or chromosomal microarray analysis. Homonogenic disorder we may detect by exome sequencing or exome sequencing plus. And for mitochondrial disorder we may detect by whole genome sequencing. Genomic medicine. Let's move to genomic medicine. Genomic medicine actually a medical discipline that involves using a person's genomic information as a part of their clinical care. We might call as individualized medicine, personalized medicine, or precision medicine. They are the same term. For some conditions, genomic information can be used to help diagnose disease, predict outcome, or guide treatment. However, it should be noted that genomic information is only one piece of the puzzle of why some people get a disease and some people don't. But this piece we can measure very accurately that can help us in the treating and even preventing diseases. Because of that, other factors are also important, such as habits, lifestyle, environment. Sometimes we may uh, think that which one the most appropriate term, whether precision medicine or personalized medicine. It usually these two terms interchangeably. However, personalized could be misinterpreted to imply that treatment and prevention are being developed uniquely for each individual, but precision medicine focus on identifying which approach will be effective for which patient based on genetic, environment, and lifestyle. When we talk about genomic medicine, precision medicine, we talk about data-driven healthcare, value-based healthcare, and better care tailored or stratified treatment. We are not talking about one size fits all approach. We are not talking about volume-based healthcare, and we are not talking about protocol-based medicine anymore. This is the simplify the scheme of traditional approach, evidence-based medicine compared to personalized approach. For evidence-based medicine or traditional approach, everybody receives the same medicine. However, they only typically 30 until 60% effective. However, for personalized approach, the treatment was tailored to match an individual makeup and respond, therefore more effective and fewer side effects. How about the precision medicine in globally? This is the Human Genome Project starting from 1990 and finished within 13 years until 2003. Why it takes so long? Because it used the first generation of sequencing called as Sanger sequencing. This is the history of sequencing technology. The first of technology is Sanger sequencing, and then second generation is short read sequencing. The third generation is long read sequencing. Sanger sequencing is slow but very good base and accurate structure. How about short read sequencing? Fast read but only good base accuracy, not structural variant. For long read sequencing, the third generation of sequencing is fast read and only good for structural accuracy. Hopefully, the new technology, the fourth generation of NGS sequencing, will be fast read with good base, both base and structural accuracy. High throughput sequencing. Before 2012, we usually called NGS as low throughput sequencing. However, now after 2012, Fares high throughput sequencing panel was introduced. And in the future, from now, there are multi-omics joint analysis as well. Because of NGS technology, the genome sequencing, the cost is declining very effectively, then more affordable. Perhaps in the future, the cost of genome sequencing less 100 US dollar. But when using the Human Genome Project, it costs more than 100 million US dollar. I think we cannot imagine how big they are if we change the currency in IDR or rupiahs. And this is the advancement in technology, not only sequencing technology, several advancement also exist now, including advances in basic science understanding of disease processes, rapid nucleotide sequencing, both DNA and RNA, epigenome mapping, gene editing using CRISPR-Cas9, stem cell technology. After COVID, we have very knowledge about big data, machine learning, artificial intelligence, and also because of COVID, blessing in disguise, we also recognize the importance of telehealth. Global Genomic Medicine Consortium. The purpose of this consortium to leverage and nurture global expertise, create practical real-world solution, and disseminate knowledge implementing genomic medicine in diverse settings around the world. Started as Action Collaborative in the United States, and also supported by National Human Genome Research of NIH. This is the global precision landscape. When we talk about precision medicine, we talk about the genome technology or the genomic advancement in that country. And this is how the global precision medicine landscape in the world. The United States just launched around 8 years ago, Precision Medicine Initiative by President Obama. And now we have application of new technology with unprecedented successful, such as technology advance occurring at light speed, cost rapidly decreasing. However, still ethics somehow a major concern. We lack the technological. Precision medicine in Indonesia. Indonesia is expected to be the big four of GDP in 2030, following China, India, and the United States. However, still 2 million Indonesians go overseas for medical treatment every year, and human resources, knowledge, and skill varies among institutions. This is our lab contribution for during the COVID SARS-CoV-2 genomic surveillance, particularly in Yogyakarta, in some part of Central Java. And then, because another advantage of NGS technology, we may detect the hepatitis unknown etiology several years or maybe several months ago, last year. And this is when the Minister of Health launched the Indonesian Precision Medicine Initiative.
Nanti akan diluncurkan inisiatif Precision Medicine-nya itu sebelum 17 Agustus sebagai hadiah ulang tahun Republik Indonesia. Kita akan luncurkan, jadi ada population genomics lengkap dengan 6 centers yang kita mau bangun. Jadi cancer, brain and neuro, infectious disease itu ada di Sulianti Saroso, kemudian Jogja itu genetic diseases, termasuk rare diseases ada di sana karena banyak rare diseases kita. Kemudian UI itu metabolic, diabetes, kemudian ada Sanglah untuk beauty and aesthetic.
At the first launch of Indonesian Precision Medicine through the Program of Biomedical and Genome Science Initiative, PGSI, there are only 6 hubs. Diabetes for Cipta Mangunkusumo Hospital, cancer for Darmais, tuberculosis for Sulianti Saroso dan Persahabatan, stroke for Rumah Sakit PON, Sarjito, our hospital for genetic rare diseases, and Rumah Sakit Ngurah for aging beauty wellness. And after 1 year anniversary, just last August 2023, the hubs becoming 8, including the maternal, reproductive neonatal health, and cardiovascular for RSAB Harapan Kita, and Rumah Sakit Jantung Harapan Kita. We may divide the 8 hubs into disease screening, disease diagnosis and treatment, and pharmacogenomics. Precision medicine approach we may classify into 2, whether the disease Mendelian, such as our hub, Duchenne muscular dystrophy, and complex genetic disorder. Mendelian approach is for genetic testing and defining genetic etiology. Genetic diagnosis guides treatment, including gene therapy. However, for complex genetic disorder, more on disease risk stratification and determine the polygenic risk. And this is comparing Mendelian and complex genetic disorder. If the variant very common, including found in, it means found in control population, then the phenotype will be very low. However, the variant is very, very rare. The possibility of the phenotype will be very high, and it happens in Mendelian diseases. For common variant, it happens in complex genetic disorder. Iceberg diseases. Iceberg diseases interesting is because complex genetic disorder characterized by the lack of ganglion cell, causing functional obstruction in children. The incidence in Indonesia is very high compared to even in other Asian countries. A role of NGS in genetics of Hirschsprung improving from only 20%, now we can detect more than 70% of pathogenic variant in patients with Hirschsprung disease because of NGS technology. And this is how do variants cause Hirschsprung. Interesting, several pathogenic variant, very, very rare, also found in Hirschsprung, then they cause large effect phenotype. However, common variant with small effect, there is also exists in Hirschsprung and such as in regulatory variant of red and NRG1. However, there is one interesting common variant with large effect of phenotype, which is red RS2435357. Another use of our NGS technology is RNA-seq. We determine the transcriptomic, including for our patient, Hirschsprung patient. And this we can find novel microRNA and established microRNA. And this is the journey of NGS, exome sequencing for Hirschsprung paper. It took several months, several revised steps because of bioinformatics. And we thank to our collaborator, Professor Christian and Delgado from Nijmegen, who help us for bioinformatic analysis of exome sequencing for Hirschsprung disease. And finally, our paper accepted in Journal of Pediatric Surgery last November. And we move to Mendelian disorder, which is our hub Duchenne muscular dystrophy. The incidence is 1 in 3,500 live births. Incidence in Indonesia, approximately 500 until 700 DMD patient a year. The patient will have progressive muscular weakness, usually 10 to 12-year-old wheelchair bound and premature death within the second decade if no gene therapy given to the patient. Because of there is a pathogenic variant in dystrophin gene, including deletion and duplication. The most, the rest is point variant. Because of this pathogenic variant, the protein dystrophin is not produced, and then it cannot maintain the skeletal muscle and manifests as Duchenne muscular dystrophy phenotype. Interesting emerging treatment for DMD, including gene therapy, exon skipping, and read-through, will lessen severity of DMD, and the patient will have longer life expectancy and higher quality of life. And we may determine the kind of gene therapy depend on the type of point or exon deletion or duplication. Fortunately, 80% patient can be treated with exon skipping strategy. And we now develop the target sequencing for DMD in our hospital. And in the last 2 months, we have discussed with one company from United States for exon skipping therapy with Sarjito Hub and Minister of Health. Hopefully, the exon skipping treatment for DMD will happen in Indonesia for our patient in the near future. And how about the challenge genomic medicine in Indonesia? At least 3 challenges in genomic medicine: privacy, cost, and ethics. Privacy, we already have Genetic Information Non-Discrimination Act, GINA. GINA prevents discrimination on the basis of genetic information regarding health insurance and employment. GINA, however, does not prevent discrimination regarding to life and long-term disability insurance. And another problem, who is going on control and access your genetic information? And what will they use it for other than healthcare? Another challenge is cost. The first challenge, who is going to pay for the testing, diagnosis, or screening? Who will pay? And how will we integrate genomic information and the needed tissue support into electronic health record? Who is going to educate physician and patient? Not only layperson doesn't understand about precision medicine. However, even clinical medical doctor, physician, some might not really understand about precision medicine. Therefore, well-designed longitudinal studies will be needed to demonstrate value before payer will sign on, and machine learning, AI, along with massive computing capability needed to fully leverage genomic medicine. The third ethics. That's a challenge, genomic medicine ethics, about designer babies, germline editing CRISPR-Cas9, and initial access primarily to those that can afford it. In conclusion, genomic medicine in Indonesia is a hope. Technology development, particularly NGS, drive genomic medicine. Indonesia is ready for genomic medicine. Challenge is genomic medicine privacy, cost, and ethics. And we do hope can join the 15th Asia Pacific Conference of Human Genetics with the topic of equitable future in genomic medicine, innovation, leapfrogging, and frontier technology for humanity 2 years later in Jakarta, Indonesia. Thank you very much again for the opportunity. And then I'm sorry I cannot attend via Zoom lively, and I just send a recorded. Hopefully, this is useful for the advancement of genomic precision medicine in Indonesia. Looking forward to having collaboration and discussion with all participants. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Yeah. Okay. Thank you, Professor, for sharing with us today. What a fascinating presentations. Actually, we still have 15 minutes, but we'll allocate the extra time for the discussions later on. Okay. We've just got some many informations and experience from listening to the lectures. I can already see a big potential from the participants. I hope there will be there will be questions related to the material that Professor Gunnes just presented. However, we will save the questions for later because we will open the discussion sections after the second speakers. And as reminders, the participants in the Zoom meeting, if you have any questions, please type the question in the chat box or activate the raise hand features, and we will back to you in the discussion sections. Okay, now we move on to the next speakers. Our next speakers is a person who allocated most of her time doing a research related to molecular pharmacology and genomic fields. Our fellow lecturers in the Diponegoro University, Dr. Nani Maharani. And as usual, I would like to read the curriculum vitae that Dr. Nani has sent to us. Dr. Nani Maharani is a lecturer in the Department of Pharmacology and Therapy, Faculty of Medicine, Diponegoro University. She is graduated from bachelor degree, medical doctor professional degree, and master degree from Diponegoro University, and she also was graduated from doctoral degree at Totoro University. She is currently served as Vice President of Indonesian Society of Human Genetics, as well as a laboratory coordinator in the Laboratorium Central, Faculty of Medicine, Diponegoro University. One of her research interests is in the field of molecular genetics of cardiovascular disease. And she has already published more than 25 papers related to molecular pharmacology and genomic research in high impacted journals. Ladies and gentlemen, without further ado, please join me in welcoming Dr. Nani Maharani. Please give the applause to Dr. Nani Maharani. So, Dr. Nani, how are you? Yeah. Okay, you have 45 minutes for your presentations. Will you make it?
Assalamualaikum warahmatullahi wabarakatuh.
Yeah. Okay, the time is yours. Yeah.
Thank you, Pak Minci, for introducing me. First of all, I would like to thank to the committee of the Ictmhs for inviting me to deliver a speech event. And also, I would like to apologize for all the audience that maybe my voice is not really nice because I still have a little cough here. Okay, today I would like to deliver the title Precision Medicine in Inherited Cardiovascular Disease. Well, the recent technology enables us to look further on our genomes, and the medicine has switched from the traditional medicine into, I don't know where my slide is, acting. No, it should be in the previous slide first.
Can you help us?
So the slide should not be further yet. Should be back to the previous slide, first slide.
Maybe operator, can you help us? Yeah.
Yeah.
The previous slide, please.
Yes. Okay. Well, the medicine has switched from the traditional medicine and with the one size fit all therapy, which is everybody would get the same therapy for the same disease. But now, with the advancement in the genomic medicine, we have switched to the precision medicine, where the therapy were based on the genomic background of each individuals, and the genomic backgrounds will direct us to the natural cause of the disease, which can lead us to the a more personalized treatment, including the pharmacotherapy. It can also be personalized, not only the pharmacology, but also the risk of developing a more severe disease, the prognosis, and also in here, precision medicine not only covered from the pharmacological side, but also to the other, for example, for the exercise, the correct exercise, the right exercise for the people, and also the nutrients, etc. So in the terms of cardiovascular disease, the genetic background of cardiovascular disease can be consist of two types, which is the cardiac disease, which with the single variant cause, we call the Mendelian disease, those cardiovascular disease which inherited in Mendelian manner, such as the hypertrophic cardiomyopathy, dilated cardiomyopathy, also the long QT syndrome, and the congestive heart disease. But there are the type of cardiovascular disease which are caused by multiple variants in different genes, and this disease is not inherited in Mendelian manner, but it's not non-Mendelian. In this case, the cardiovascular disease could be caused by several genes acting together to cause the phenotypes. But in this presentation, I would like to focus on the cardiovascular disease with single variants genes, single variants in single genes, but only few of I will talk about the non-Mendelian. With this genotype basis, we can see for the phenotype, which is the genotype basis of the genetic, the cardiovascular can direct us to the more precise diagnosis, and we can arrange the targeted therapy and also risk stratification and the reproductive decisions for the patients. And here the monogenic or inheritance in monogenic cardiovascular disease is ultra rare or rare genetic variation, but usually it has the large effect, or we call it high penetrance, while the polygenic disease, the variants might cause only a small effect. And then here, there's a chance also for the gene environment interaction. In between, there's a oligogenic or inheritance, a rare genetic with a moderate effects. And in most of cardiovascular disease with single cause or single mutation in a single gene inherited in autosomal dominant manner, yeah, most of them. But also the autosomal recessive and X pattern might also be observed. So here are the some of the inherited cardiovascular disease. I think this is the most inherited cardiovascular disease consists of cardiomyopathies, arrhythmic disorders, the thoracic aortic aneurysms and dissections. And also, I would like to talk about a little about the cardiovascular abnormality, which is the part of genetic syndromes. For example, the Noonan syndrome or the Rasopathy syndrome. In those cases, in those disease, genetic testing is needed, yeah, to confirm the diagnosis and later to adjust the management as appropriate. So this is what we call the precision medicine, looking into the genetic background to see the nature of the disease, and then we can adjust to the most appropriate management for each patient. And I should note here that the genetic testing might not reveal the cause or confirm the diagnosis. Well, here because there might be, we might found some variants with we don't know or we not sure whether the variant is pathogenic or the causative variant for this disease. In this case, genetic testing might reveal or confirm the diagnosis. So for the first disease, I would like to talk about the inherited cardiomyopathy. And this is the disorder of the myocardium due to genetic defect. It consists of hypertrophic cardiomyopathy, and it can also be in the form of dilated cardiomyopathy and arrhythmogenic cardiomyopathy. So in here, yes. So in inherited cardiomyopathy, the genotype, the basic of the disease will cause the phenotype, which is here. Each individual will have genetic backgrounds. It will be influence the burden of care, and also in the other side, there might also be individual environmental factor, but in this inherited cardiomyopathy, the effect of the environment factors is not so big as the acquired cardiomyopathy. So if we look at the genes which cause the cardiomyopathy diseases, we can see from this picture that this is the cardiac cells. And here we can see the cell membranes and so also the striated cardiomyocytes. And here, the location of the genes will influence, of course, the phenotype of the cardiomyopathy. Here, the hypertrophic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy, the genes are usually clustered in the sarcomere. So we can see in the central the genes which are involved are TNSCC1, TNAT2, TPM1, ACTC1, LDB3, FLNC, TTN, MIP, C3, MYH7, MIL2, and MIL3. And also those genes which are in the desmosomes, TMAM43, DSP, DSG2, DSC2, JUP, and PKP2. The genes, the variant, pathogenic variants which located in the sarcolemma or that links the sarcolemma and extracellular matrix to cytoskeleton. That is the SCN5A, DMD, DES, PEC3, PLN, LMNA, RBM20 are usually causing the dilated cardiomyopathy. So by looking at the causal genes, we can group it, or we can see the basic genetics of the nature of the cardiomyopathy. So how to implement precision medicine in the case of cardiomyopathies? Well, here first that establishing a clinical diagnosis of cardiomyopathy is the most important thing. The first thing we should do, and we look at the phenotype. I think the clinical features, which we can group the patients into whether they have the hypertrophic cardiomyopathy or dilated cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy. And then from there, we identify the causative factors. We can see whether there is the gene mutation, the background genetic variation, and also we can see whether the patients have comorbidities and lifestyle factors. And also we do the more on phenotype assessment, like for example, we do the electrocardiography, echocardiography, or we check for the histological structure of the cardiomyocyte. From there, we can derive the risk stratification and arrange for the precision management. So risk stratification and precision management will be based on the variant or gene mechanism-based therapy, or we can the targeted use of the heart failure or anti-arrhythmic therapies, and also if we detect some risk factors, lifestyle factors, we treat the modifiable risk factors. So not only in terms of pharmacological treatments, but also the modifiable risk factors. This is some example of implementation personalized medicine in inherited cardiomyopathy. For example, patients with the variant P are beginning at 222Q in the SCN5A gene. They can be effectively treated by sodium channel blocker, for example, fekainid, amiodarone, and quinidine. And those the carriers of sarcomere gene mutation might have an earlier onset of disease and high rates of sudden cardiac death. And arrhythmogenic right ventricular cardiomyopathy patient with pathogenic desmosomal variants might have earlier onset disease and ventricular arrhythmia. So this in these patients, the threshold for the intracardiac implantation may be lower. So we have to do the ICD implantation earlier than the other type of patients. In here, the exercise prescriptions should also be individually tailored according to the patient-related factors. Next, we move to arrhythmias. So most causal gene for inherited cardiac arrhythmias encode the cardiac ion channel protein. So and most of them are inherited in autosomal dominant manners, and the rest of it can be autosomal recessive or the X-linked. And this is the arrhythmia is the major cause of sudden cardiac deaths. The example of inherited arrhythmia or the long QT syndrome or QTS, Brugada syndrome, the catecholaminergic polymorphic ventricular tachycardia, and the familial atrial fibrillation. So for long QT syndrome, usually patients will have increased risk of syncope and sudden cardiac death. And the LQTS consists of some types, the LQT1, LQT2, LQT3, which each have phenotypic, for example, the LQT1 is triggered by emotional distress or physical activity. The LQT2, usually the patients will be triggered by sudden noises, hypokalemia, and postpartum period. And the LQT3, most common happen during sleep or rest. And those in the right side are the genes that contribute to the event of the long QT syndrome. For example, the KCNQ1, the potassium channel gene, KCNH2, sodium SCN5A or CALM3, and those are definitive evidence with the definitive cause, the strong evidence of causing the LQTS. And the next to it is those the genes which has strong or moderate evidence, like CACNA1C or TRDN, and some other genes have limited or disputed evidence for the LQTS. So in here, the location and the type of mutation, for example, whether the mutation is missense, frame-shift, or splice site, will affect the degree of ion channel dysfunction and phenotypic manifestation. For example, here mutation that affect the transmembrane lead to more severe electrophysiology phenotypes. Those patients with those mutation tend to manifest in younger age and carry greater risks of adverse cardiac events. So for some mutations, we should aware that the patients might have worse prognosis. So this is the example of the genotype-guided risk stratification and management. After we collect or we know the causative genes, we can have the how to correctly manage the patients. Like for example, for long QT1 type 1 with the mutation on the KCNQ1, the patients should avoid the emotional or physical distress. And in these patients, the antiadrenergic therapy, for example, nadolol, will be highly effective. And so for the long QT type 2, and with the mutation on KCNH2, it's usually should be treated by aggressive monitor or replay potassium and avoid the noise, exercise caution. And in these patients, the use of non-selective beta blocker, for example, nadolol is preferred. And then in long QT3 with the mutation in SCN5A, here the use of beta blocker, nadolol or propranolol, the non-selective ones, are preferred. And sodium channel blocker if the QT interval is more than 500 milliseconds. Next is Brugada syndrome. Brugada syndrome is high risk of ventricular arrhythmias and sudden cardiac death. With the genetic basis, the definitive evidence is the mutation on SCN5A. In here, in the Brugada syndrome, there are also type 1, type 2, type 3. But here, the role of genetic testing is as well established as those in long QT syndrome. So this is the illustration, the overview from the long QT syndrome, the Brugada syndrome, and also I have to add here the familial atrial fibrillation, which atrial fibrillation can be caused by metabolic factors, for example, like obesity or hyperuricemia and causing atrial remodeling. But also if it's familial, then it's inherited atrial fibrillation, which we can also get direction on the current and future precision medicine. The next cardiovascular disease is heritable thoracic aortic disease. There are some thoracic aortic disease, but I would like only talk in detail about Marfan syndrome because this is what I learned during my master's study. And Marfan syndrome is a connective tissue disorder which is inherited in autosomal dominant manner. And the clinical phenotypes of Marfan syndrome, usually the patients have a tall stature with long fingers or arachnodactyly, and lens dislocation, high myopia, and also the cardiac manifestations usually consist of the aortic aneurysm and dissection, or the abnormalities on cardiac valves. So here, the mortality and morbidity mainly caused by dissection of or rupture of the aortic aneurysm. And the cause of this Marfan syndrome is pathogenic variant in the fibrillin gene, one of the component of the connective tissue. And there are two types of the effect of variant in fibrillin 1 gene. And the variant can be causing haploinsufficiency, which is the amount of normal connective tissue, or normal fibrillin is less than sufficient amount. But also the variant might cause dominant negative variant where the variant cause the abnormal form or disrupted form of fibrillin. And what interesting in Marfan syndrome is that this disease might cause phenotypic variability among family members. So what we do in Marfan syndrome, the current therapeutic strategy consists of thoracic aortic surgery in the presence of aortic aneurysms, vascular thoracic aortic aneurysms, or the prosthetic aortic valve replacement, and also the antihypertensive treatments, the pharmacological treatment can consist of antihypertensive to reduce the heart rate and blood pressure. So here, the antihypertensive treatment can decrease the stress or the pressure on the weak aneurysm. Yeah. Marfan syndrome patients with haploinsufficient mutation are at increased risk of cardiovascular death and aortic dissection compared to a patient with dominant negative mutation. So differentiate whether the patients have a haploinsufficiency or dominant negative is essential here. The surgical approach consists of total aortic root replacement or valve sparing procedure, and also the beta blocker. We can use the propanolol, atenolol, or nebivolol, aimed at decreasing heart rate, lowering blood pressure. And the angiotensin receptor blockers, we use losartan and valsartan. And these angiotensin receptor blockers have dual goal. One is as the antihypertensive. Another is that the ARB have effect on slowing the aortic root growth rate in Marfan syndrome patients. So here, the use of ARB is both beneficial in terms of reducing hemodynamic stress as well as to decrease the aortic root growth rate. And this from the pharmacogenetic point of view, losartan is effective for patients with haploinsufficient mutation and not the dominant negative. And this is the current finding of the Marfan syndrome treatment, and that the type of the mutation might also direct us or predict the effect of pharmacogenetics therapy, especially for the use of ARB. And here, the earlier intervention is initiated, the better the outcome. So, achieving the definitive diagnosis of Marfan syndrome is suggested to so the patients can be earlier getting the intervention. The last disease is the cardiovascular abnormalities as part of syndrome. I would like to talk about rhizopathies. This is our current research in the genetic groups. That rhizopathies is group of genetic disorders which result from the germline mutation, pathogenic mutation in the RAS MAPK pathway. And the example of rhizopathies are Costello syndrome, Noonan syndrome, cardiovascular-cutaneous syndrome, and neurofibromatosis. So the disease characteristics by distinct facial feature, developmental delays, cognitive impairment, and heart problems. So this is the involvement of genes in rhizopathies. So here for the RAS and MAPK signaling, the location of the defect gene can be various. And here, for example, for the Noonan syndrome, it can be caused by the mutation in RAS, SOS1. Most of the mutation are in BTPN11, CBL, RIT1, etc. And by blocking the RAS pathway will be beneficial for therapy. We can target the RAS either upstream or downstream to of the RAS MAPK pathway. So we can expect the signaling can be resolved. Some drugs are now under development for or in clinical trials. For example, the MEK inhibitor, the trametinib, selumetinib, and also the multiple kinase inhibitor, dasatinib, and some other drugs are currently under development. So I would also like to talk some about the NGS, or next generation sequencing, because with the advancements in the detection for genomic variants, now we have the next generation sequencing, which is the difference between the NGS and Sanger sequencing is that the next generation sequencing enables us to analyze multiple genes simultaneously. And so in here we can we can find variants in the multiple genes in one time. So usually for the NGS-based approach in cardiovascular genetics, it consists of three approaches. The first is about the using the targeted gene panels. In here we use a set of genes which is previously known as to have the correlation or with the cause of the disease. And then the exome sequencing consists of clinical exome sequencing, which usually consists of 5,000 to 7,000 clinically relevant genes. So not only genes with correlation with the cardiovascular, but also the other clinical phenotypes. And also we can do the whole exome sequencing, which can cover all exomes in our genome. And we can also do whole genome sequencing if we can not found any suspected variants in with the whole exome or targeted gene panels. We can also do the whole genome sequencing, which we look at the whole genome to see the pathogenic variants outside the exon, which can cause the difference in gene expression, for example, those variants in promoter or in splice site. So understanding on the genetic basis on inherited cardiac condition is needed to select the appropriate genes to be included. But our effort not only ended by finding the variants, but also we need to interpret the variants, whether the variance is pathogenic or likely pathogenic to be concluded as the cause variance for our disease. So this is determining the clinical importance of the variant that we found. Is the variant pathogenic, likely pathogenic, or whether the variant is benign or likely benign, or whether the variant has uncertain significance. So for the variant interpretation, we can use some tools that are available online. For example, the ClinVar database, the genome aggregation database, where we can look for the frequency in population. Usually those with likely pathogenic or pathogenic are very rare or ultra rare in the population. The gold standard is to do functional analysis, but of course it might cost expensive and maybe very laborious things, but this is the gold standard for variant interpretation, or we can also do the segregation analysis. The more proof to get into the clinical description of this variant is very important. Yeah, sometimes the NGS diagnostic yields varies. So as I mentioned previously, that not all variants, not all genetic examination that we do, we get the causative or likely causative genes. So for example, in the hypertrophic cardiomyopathy, only around 47 of until 72% diagnostic yields. And in some other cardiomyopathy much lower, like in ARVC or RCM. And in Brugada might only the yields of 20%. And here the what is it? The diagnostic we can get the genetic diagnosis for cardiac disorders is sometimes not all 100%. So maybe this is good to summarize the precision medicine workflow in genetic heart disease. So when we see the patients, we have patients with certain genetic heart disease. We do the phenotyping, like we collect the blood, urine, or breath, or biopsy, sample collections to see the marker, where we examine for the DNA for the variants. And yeah, we call it do deep phenotyping, which is consists not only clinical phenotype, but also in deeper, like we look at the multiomics, metabolomics, proteomic, transcriptomic, or the genome phenotype. Sorry. And for more precise, you can also do the in vitro disease modeling to see whether this variant is really causative or pathogenic. And then from that, we got the precision medicine candidates. So from there, we can develop the novel therapies, which is in here. We can test for the in vivo safety and efficacy of the treatment, and then we can apply the treatment strategy to the patients. And here in the right side of the graph, from the deep phenotyping, we can get the disease marker, the information on disease marker. We might find the novel biomarkers, and from there we can have the accurate disease monitoring and to be applied to the patients. So maybe the previous examples are only a few part of modalities in precision medicine. The other modalities for precision medicine is also can be in the form of other modalities. For example, using gene expression modulation, using, for example, the small inhibitory RNA, synthetic microRNA, and here the gene silencers, and we can also modify the gene expression using the molecules that can modify the transcription factors of the gene, and also we can affect the signal transduction using signal transduction modulators. We can also do the gene editing for the disease with a single gene mutation of the variants. And recently, the development of intrabodies. This is similar to antibodies. This is also in the development for the modalities in precision medicine, and also the development of small molecules, which can also be the options of the modalities in precision medicine. So in conclusion, the genetic component is the main feature in inherited cardiovascular disease. And genetic testing is needed to confirm the diagnosis and direct the clinical management, although not every testing will reveal the cause or confirm the diagnosis. Here, the deep phenotyping is as much important to establish the diagnosis and lead us to precise medicine, and that the precision medicine in inherited cardiovascular disease can be done to can be done with several modalities. So I would like to thank you for your attention, and wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much for your presentations, Dr. Nani. You may come forward and sit on the chair here. We already provide you. Okay. And I've got some information that Professor Gunedi has joined us in a Zoom meeting today. Are you there, Professor? Okay, we will be back again with professors. And thank you, Dr. Nani. There are many positive benefits we can learn from your presentations. And thank you for the participants who have been waiting to ask questions. Now it is time for the discussion sections. I think we already got some questions today in the Q&A. Can you show us to the participants? Yeah, please wait for a moment. We're still working on the questions. Okay, we got several questions here. One for Dr. Nani and one for several for Dr. Nani and also several for Prof. Gunadi. I think we proceed with questions to Dr. Nani first. Professor Gunadi, is there already? If it's not, then we can proceed with the Dr. Nani first, I think. Yeah. Okay, for the questions for Dr. Nani, the first question is from Dr. Yora, which is also a lecturer from Faculty of Medicine, University of Diponegoro. So the question is, which one is better, DNA or RNA sequencing for clinical precision medicines in the future? And what is difference and advantage or disadvantage of the two tools for the precision medicines? Okay, maybe you can just answer it one by one.
Okay. Thank you for the question, Dr. Yora. So the question is, which one is better, DNA or RNA sequencing for clinical precision medicine? It actually depends on the purpose of the purpose on what you are looking for. For example, if for DNA, DNA is the same in all cells in our body. The DNA is what's it? Exact type. It's the same. Yeah. So usually we look at the DNA for the variant, for example, in the Mendelian disorders, or to see whether there is a mutation of pathogenic variants in a gene. But for RNA is expressed differently in each type of cells. So the RNA expressed in for example, the cardiomyocytes, compared to the neurons, and compared to, for example, the adipocytes, it's different. So the RNA, we look at RNA usually if we would like to see what genes are expressed in certain tissue or certain cells. For example, in the study of cancer, which is the cancer happened in a certain types of cells, certain location of the cells. We take the tumor cells and extract the RNA and do the RNA sequencing, and we can see um, the gene expression uh, in that cells. But for the DNA, we cannot see the gene expression profiles, so the DNA will be the same in all. Yeah, if we would like to see, for example, if we would like to see the exact disease mechanism or the pathogenesis of certain cancer, we can take the RNA, yeah, to get a better view on what genes are uh, involved in that pathogenesis for that cancer. I hope it answered your question.
Yeah, so it depends on the purpose. Yeah, so for the cancer, it's
Yeah.
better for RNA because you will have a good view on the expression.
It depends on the purpose. Yeah.
Okay, next is the second question from Bu Nana Rohana, also from Faculty of Medicine, University of Diponegoro. If someone has been detected to have a significantly higher risk to have inherited genetic disorder upon the examination and test, could the disorder be prevented by doing genetic modifications or interventions? So Bu Nana Rohani is also a nurse. So related to the genetic disorder, to what extent nurse can play a role in this field, apart from the genetic counseling role?
Yeah.
Maybe
Okay,
you
thank
can
you for
answer.
the question, Bunana. So if someone has detected to be a significantly high risk to have inherited genetic disorder upon examination and test, yeah, in in your question, I assume it based on the family history.
Yeah, probably from the family history. I think.
Family history, yeah. Usually, if those disease, somebody have a family history of a certain genetic disease, we can what is it? If it's something that um, kalau sesuatu itu dia bisa, the disease we can do something on the disease, yeah. Usually we will examine to see whether there is a pathogenic variants in that persons or not. So here I assume in your question that someone has not developed the genetic disorders yet. Yeah, we do the genetic examinations if the disease is the term is something that what is it dapat diperbaiki, yeah. If the disease we can do something on the disease. But for those disease which we don't have any treatment yet, usually we don't do the genetic screening for those this is for the family. Yeah, but if somebody has suspicion she is having the genetic disorders, so the genetic examination must be done as soon as possible to confirm the diagnosis. But if they are not having the sign of symptoms yet, it depends on the disease whether it is we can do something with the disease. We do the screening, and if not, then we don't do usually. Yeah. And if that disorder could be prevented by doing genetic modification or intervention, well, actually, until today, the intervention on it, in this case, the genetic modification, right? Genetic modification now is some trials have been going on, but usually those modification are only for the disease which has single mutations or hotspot mutations, or the disease, for example, like the DMD that Prof. Nadi talked about, caused by exon skipping, in some groups of patients they have similar types of mutation or the same type of mutation. Now have been going on some trials for the genetic modifications, but for most of the genetic disorder, we don't have genetic modification or intervention yet. Of course, in theoretically, it is possible in vitro by using the CRISPR-Cas9 with the editing of the gene. Yeah, but most of them are still ongoing clinical trials. Yeah, and then I think it answered your first question. Okay. And then for the second question, I'm a nurse related to genetic disorder. To what extent can play the role in this field? Yeah. At first, if we are, what is it, familiar with the clinical presentations of genetic disease, then we can suggest the patients to do the genetic examination. For example, if you're familiar with the clinical manifestation of Down syndrome or Marfan syndrome, we can suggest the patients to do genetic examination to confirm the diagnosis of the genetic disease. Yeah, I think besides the genetic counseling, that's what we can do as a nurse.
Yeah, so the first things to do is diagnosing, yeah, because that is
Yeah,
the first
definitely.
line that you have to do. And then for the nurse and for the genetic modifications is still limited at the moment because still have you need some studies, especially with the inventions of CRISPR-Cas9. And then for the nurse can suggest the patients to do the examinations for the genetic, of the patients. Okay, next for the questions for Professor Gunadi. I will need to confirm again. Professor Gunadi, are you there at the moment? Yeah. Yeah, the same questions?
Same question?
Yeah, I think it's same questions because the questions is not specifically for only Dr. Nani. Yeah, so it's a general question, I think. Yeah. So the question has been answered by by Dr. Nani. So Professor Gunadi, do you have any additions from Dr. Nani answer? Okay. So Professor Gunadi, maybe we can just answer it outside from these sessions because Professor Gunadi has already answered it, but via WhatsApp. Yeah, maybe. Okay, from the PIC. Can you send it to us, maybe? So actually, Professor Gunadi has already answered the questions. We're still working on with his questions. Okay. Okay, so the answer will be provided after the session. So we will post the answer in the Zoom meeting online or maybe in the emails, especially for the person who give the questions. Yeah. Okay, because we still have time, maybe I answer the question. Have some questions, yeah.
Okay.
Because actually my literature thesis is about the CRISPR-Cas9, yeah. So is it a good tools for the genetic modification, also for personalized medicines, and what is the perspective and also what is the future prospect of the CRISPR-Cas9 related to the other tools? Is it efficient or is it a good tools related to the others? Maybe
Yeah.
I think that's the question that we have to answer because it is the newest inventions in the genetic modifications.
Yeah, okay. Thank you, Pak Wimsy. Well, I'm not doing the CRISPR-Cas9 myself. I can only answer based on what I knew about, a little about the CRISPR-Cas9. Well, for the CRISPR-Cas9, I think the application, we can do the gene editing in outside the patient body or inside patient's body. And usually the problem is with the right target. If it's off target, then we have problems, and we have the CRISPR-Cas9 has to be reaching the right gene, the target gene of what we targeting, and then also the problem might caused by the off target, and it is editing the genes outside of the cells or the place that we want, and also the genes itself might in the expressed in other cells. Yeah, that's also maybe it will cause the a problem. But yeah, I only know that little, so I might not answering the whole of your question.
But
Okay.
that's enough, I think, because CRISPR-Cas9 I think is more selective than the other tools. Yeah, but maybe that can answer the selectivity problems of the genomic editing.
Yeah.
Yeah. Okay, I think the questions is enough. So it marked the ends of the discussion sections. And please allow me for as a moderator to sum up some key informations we gathered from the lecture. So from Professor Gunadi, there are several genetic disease that is classified into different categories. The chromosomal disease, single gene disorder, mitochondrial disease, polygene disease, and somatic cell genetic disorder. And the inventions of the next genomic sequencing helps identify to diagnostic this type of the disease. And precision medicine and personalized medicine help us to identify and such variations in the genetic and help us to deliver good treatment, best treatments, and also to get a better understanding on the options to cure the disease. And the use of genetic informations is still lacking in Indonesia, and it should be encouraged in order to give a better therapy for the patients. And from Dr. Nani, there are several cardiovascular disease, which is also related with the personal medicines. And it fell into the category of Mendelian disorder. There are most of Mendelian types in inherited cardiovascular disease is, for example, cardiomyopathy, arrhythmic disorder, thoracic aortic and aneurysm disease, and then Marfan disease and cardiovascular abnormality related to genetic syndrome. And genetic testing is needed as a diagnostic procedure to confirm types of cardiovascular disease, especially for inherited one. And the use of personal medicines may limit or even cure the inherited cardiovascular disease. And advance in the detections of the variants using the next genomic sequencing make it easier in diagnostic such variants. And usually there are three methods that has used for next genomic sequencing. The first one is targeted gene panels, and then exome sequencing, and the last one is whole genome sequencing. And some modalities of precision medicines can be used, for example, gene editing, gene silencing, and small molecules to limit and cure inherited cardiovascular disease. Okay, thank you for all the speakers for sharing your knowledge and experience with us today. And thank you all the participants attending this event. And as an appreciation, we would like to give a certificate for both of the speakers. Can you show us, maybe? Yeah, the certificates. Yeah, the first certificate, we humbly hand over it to Dr. Nani Maharani as an appreciations. And this certificate has had endorsed by the Professor Dr. Dwi Puchanarko as Dean of Faculty of Medicines as appreciations. And we thank you to Dr. Nani as the valuable informations, and we learn a lot from you related with the personal medicines in the inherited cardiovascular disease.
Excuse me, Pak MC. Seems that the
Oh, yeah.
certificate will be
Okay.
given.
I think because you're here, then we will give you the certificate directly, and maybe we can take a picture of it.
Yes, we'd like to invite the head of Nutrition Science Department, Professor Ani Margawati, to provide the first certificate to Dr. Nani Maharani as the speaker. Thank you. And the second certificate will be awarded to our moderator, Mr. Wimsey. Could you please receive the certificate from Professor Ani Margawati? Thank you, Professor Ani and Mr. Wimsey. And ladies and gentlemen, the last certificate will be awarded to our first speaker, Professor Gunadi. The committee, could you please